The subject of today's laboratory demonstration is the study of adrenergic agents on the cardiovascular system. The objectives are as follows. First of all, to examine the dose-response relationships of epinephrine on the cardiovascular system. Secondly, to study the effect of sympathomimetic drugs on the cardiovascular system, and this is divided into the following four categories. A, effects mediated through alpha-1 receptors. B, effects mediated through alpha-2 receptors. C, effects mediated through beta-1 receptors. And D, effects mediated through beta-2 receptors. The third objective is the reflex homeostatic adjustments of the animal to sympathomimetic drugs. The sympathetic nervous system is important in regulating the activities of organs such as the heart and peripheral vasculature, especially in response to stress. The effects of sympathetic nerve stimulation are mediated by the release of norepinephrine from adrenergic nerve terminals. Let us first consider the release of norepinephrine from an adrenergic nerve terminal. In the diagram, we have a presynaptic nerve terminal and a postsynaptic cell. Norepinephrine is stored in granules in the presynaptic nerve terminal, and on arrival of a nerve action potential and the influx of calcium, norepinephrine is released to the synaptic cleft. This norepinephrine can act on alpha or beta receptors on the effector cell, mediating a response. The effect of norepinephrine is terminated by a number of mechanisms. First of all, we have reuptake into the presynaptic nerve terminal, followed by repackaging of the norepinephrine into the granules. Secondly, norepinephrine can diffuse from the synaptic cleft. And thirdly, norepinephrine can be metabolized by enzymes which will inactivate norepinephrine. Based on extensive studies on the potency of a series of sympathomimetics on isolated cardiac and smooth muscle preparations, Alquist in 1948 proposed that catecholamines acted on two different receptors, and these he designated as alpha and beta. The concept of alpha and beta receptors is shown in the next table. Alpha receptors have the following order of potency. Epinephrine is more potent than norepinephrine, which in turn is more potent than isopropyl norepinephrine. And this response is blocked by the drug tolazoline. Beta receptors have the following order of potency. Isopropyl norepinephrine is more potent than epinephrine, which in turn is more potent than norepinephrine. And Alquist proposed that drugs would be developed which could in fact block these responses. Propranolol, one such drug developed, will in fact block these responses. Now, Alquist's hypothesis was confirmed by the development of drugs that selectively antagonized alpha and beta receptors. It was later shown that at least two subtypes of beta receptors exist, and these were designated as beta-1 and beta-2. Beta-1 receptors and beta-2 receptors are defined by the affinities for epinephrine and norepinephrine, and this is shown in the next table. Beta-1 receptors, on beta-1 receptors, epinephrine is equipotent to norepinephrine. However, on beta-2 receptors, epinephrine is a lot more potent than norepinephrine, which has minimal effects on beta-2 receptors. The distribution of beta-1 and beta-2 receptors is shown in the next diagram. The beta-1 subtype of receptors are found in the heart, where they mediate an increase in the force and an increase in the rate of contraction of the myocardium. Beta-2 receptors, on the other hand, are found on smooth muscle preparations, where they decrease the response of smooth muscle to sympathomimetics. Examples of drugs which act relatively selectively on beta receptor subtypes are shown in the next slide. Examples of drugs which act relatively selectively on beta receptor subtypes are shown in the table. Norepinephrine acts as an agonist on beta-1 receptors, and this effect can be blocked by the antagonist metoprolol. Salbutamol acts as an agonist on beta-2 receptors, and this effect can be antagonized by the drug butoxamine. In contrast, epinephrine acts as an agonist on both beta-1 and beta-2 receptors, and this is blocked by the drug propranolol. Now, more recently, with the development of receptor blocking drugs, two types of alpha receptors have also been identified, namely alpha-1 and alpha-2 receptors. The selective agonists and antagonists of alpha receptor subtypes can be seen in the table. Methoxamine acts as an agonist of alpha-1 receptors, while prazosin is the antagonist. On alpha-2 receptors, clonidine acts as an agonist, and this effect is antagonized by yohimbine. The distribution of alpha receptor subtypes and the tissue response can be seen as follows. Alpha receptor 1 subtype is seen in vascular smooth muscle, where the effect elicited is a contraction of the vascular smooth muscle. Alpha-2 receptor subtypes are seen in certain vascular smooth muscle preparations, and again the response is contraction of the smooth muscle. In addition, alpha-2 receptors are located presynaptically on both adrenergic and cholinergic nerve terminals, where they mediate a decrease in the release of neurotransmitter. The blood pressure response to sympathomimetic drugs is therefore due to the following. First of all, vasoconstriction. This is seen in blood vessels having alpha-1 and alpha-2 receptors. Secondly, vasodilatation. This is seen in blood vessels having beta-2 receptors. Thirdly, cardiac stimulation, which is mediated by beta-1 receptors, and finally, the homeostatic response of the animal to the above. Blood pressure regulation in the animal is mediated by the vasomotor center in the brain. This center monitors blood pressure in the carotid sinus and the aortic arch, and afferent impulses are sent to the vasomotor center. The vasomotor center then regulates the sympathetic outflow to the heart and to the vascular smooth muscle, as well as to the adrenal gland. Therefore, if the monitors in the carotid sinus and the aortic arch sense an increase in blood pressure, the vasomotor center will send out a decreased sympathetic tone to the heart, to the arterioles, and to the adrenal gland, with the overall effect of decreasing the blood pressure. To come back to the objectives, the first objective stated that we were going to examine the dose-response relationship of epinephrine on the cardiovascular system. The preparation that we are using is the dog, which has been anesthetized with sodium pentobarbital, 30 milligrams per kilogram. A femoral cannula has been inserted into the artery in order to monitor blood pressure. The femoral vein has been cannulated for the infusion of drugs. Both carotid arteries have been exposed in order to demonstrate the carotid reflex in adjusting blood pressure in the intact animal. The reason for demonstrating the dose-response relationship of epinephrine on the cardiovascular system is that beta-2 receptors in blood vessels are sensitive to much lower concentrations of epinephrine than are alpha receptors. This is shown in the dose-response diagram to epinephrine. Our first response will be an injection of saline. This is being monitored on a physiograph as the systolic and diastolic blood pressure. As we can see, an injection of saline gave no change in the blood pressure response monitored. The effect of epinephrine at a low dose will be examined. Following this low dose of epinephrine, we anticipate a drop in blood pressure because of the marked sensitivity of beta-2 receptors in blood vessels of skeletal muscle. As anticipated, an injection of 0.1 micrograms per kilogram of epinephrine gave us a marked decrease in blood pressure due to selective activation of beta-2 receptors located in skeletal muscle. Because of the low dose of epinephrine injected, the duration of the response is also short. As the dose of epinephrine is increased, alpha receptor mediated vasoconstriction will predominate. Following an injection of a large dose, 1.5 micrograms per kilograms of epinephrine, we expect an increase in blood pressure because the overall effect of stimulating alpha and beta-2 receptors in blood vessels is vasoconstriction, leading to an increase in peripheral resistance and an increase in blood pressure. In addition, epinephrine acts on beta-1 receptors in the heart to increase the force and rate of contraction. The initial response we see is due to an increase in the force and rate of contraction mediated by beta-1 receptors in the heart. This is followed by a marked increase in blood pressure due to the overriding effect of the alpha-1 and alpha-2 receptor mediated vasoconstriction, which outweighs the beta-2 mediated vasodilatation. Note also the marked slowing of the heart due to the increase in blood pressure. This is mediated through the reflex effect through the baroreceptor center. The duration of the response is terminated due to the metabolism of epinephrine, the reuptake of epinephrine by adrenergic nerve terminals, and finally by the diffusion of norepinephrine from the receptors. In summary, therefore, a low dose of epinephrine leads predominantly to activation of beta-2 receptors in skeletal muscle, which leads then to a decrease in blood pressure. In contrast, a high dose of epinephrine leads to activation of beta-1 receptors in the heart, followed by activation of alpha-1 and alpha-2 receptors in the vasculature, which lead to vasoconstriction and an increase in blood pressure. The second objective in today's laboratory exercise is to examine the effect of sympathomimetic drugs on the cardiovascular system. First of all, let's look at the effects mediated through alpha-1 receptor activation. As previously discussed, selective agonists and antagonists have been developed to distinguish between alpha-1 and alpha-2 receptors. This can be seen in the diagram. The alpha-1 subtype is activated by methoxamine, and prazosin acts as the antagonist. The alpha-2 receptors are activated by clonidine, and yohimbine is the antagonist. Following infusion of methoxamine, a selective alpha-1 agonist, we would expect an increase in blood pressure due to the alpha-1 mediated vasoconstriction. As anticipated, following infusion of 100 micrograms per kilogram methoxamine, an increase in blood pressure was obtained due to the alpha-1 mediated vasoconstriction. As you'll remember from the table, prazosin acts as an antagonist of alpha-1 receptors. Thus, if methoxamine is infused immediately after prazosin, the alpha-1 receptor mediated increase in blood pressure should be blocked. As expected, methoxamine, 100 micrograms per kilogram, given immediately after prazosin, 10 micrograms per kilogram, had a minimal effect on the blood pressure, confirming that prazosin blocks the alpha-1 receptors, preventing methoxamine from increasing the blood pressure. In the table, clonidine was listed as an alpha-2 receptor agonist and yohimbine as the antagonist. Since alpha-2 receptors mediate vasoconstriction, as well as having a presynaptic effect in decreasing neurotransmitter release, the immediate effect of clonidine would be an increase in blood pressure. As expected, when clonidine, 3 micrograms per kilogram, was infused into the dog, an increase in blood pressure was obtained due to vasoconstriction mediated through activation of alpha-2 receptors. These alpha-2 receptors are thought to be located on smooth muscle in the lung. Note also the reflex slowing of the heart, which is triggered through the baroreceptor reflex. The antihypertensive effect of clonidine is due to the decrease in sympathetic outflow from the vasomotor center, which is mediated through activation of alpha-2 receptors. However, an overdose of clonidine can elicit hypertension, as was demonstrated. Yohimbine is a selective alpha-2 antagonist, and we would predict that the alpha-2 mediated increase in blood pressure produced by clonidine should be blocked by giving yohimbine immediately before clonidine. As expected, when clonidine, 3 micrograms per kilogram, is given immediately after yohimbine, 400 micrograms per kilogram, no change in blood pressure was observed. Yohimbine, the alpha-2 receptor antagonist, is useful in autonomic insufficiency by promoting norepinephrine release through blockade of presynaptic alpha-2 receptors, allowing more norepinephrine to be released. As previously mentioned, beta receptors were the first to be subdivided into beta-1 and beta-2 subtypes. This is shown in the table. Beta-1 receptors are located mainly in the heart and mediate an increased force and an increased rate of contraction. Beta-2 receptors are found in smooth muscle, for example, vascular smooth muscle, in skeletal muscle, and mediate relaxation and therefore vasodilatation. We will now demonstrate the cardiovascular responses obtained on beta receptor stimulation. Following infusion of the beta-2 agonist salbutamol, we would expect a decrease in blood pressure due to vasodilatation of blood vessels in skeletal muscle. As predicted, when salbutamol, 10 micrograms per kilogram, was injected, a marked drop in blood pressure is seen. This is due to activation of the beta-2 receptors on blood vessels in skeletal muscle. Salbutamol and other beta-2 agonists are used as bronchodilators and also to relax uterine smooth muscle in the treatment of premature labor. This decrease in blood pressure observed with salbutamol should be antagonized by injecting butoxamine, the beta-2 receptor antagonist, before salbutamol. As expected, when butoxamine, 3 milligrams per kilogram, was infused before salbutamol, 10 micrograms per kilogram, no change in blood pressure is recorded, indicating that butoxamine had effectively antagonized the effect of salbutamol on beta-2 receptors. In order to demonstrate beta-1 receptor mediated changes in blood pressure, we will use epinephrine, which acts on both beta-1 and beta-2 receptors, as well as on alpha-1 and alpha-2 receptors. We will block the alpha-1 and alpha-2 receptors, as well as the beta-2 receptor mediated responses, leaving only the beta-1 receptors free. Since a large dose of epinephrine activates both alpha and beta receptors, and since the alpha-mediated response, which is vasoconstriction, outweighs the beta-2 mediated vasodilatation, we would expect an increase in blood pressure. As expected, following infusion of a large dose of epinephrine, we have an initial response due to activation of beta-1 receptors in the myocardium, leading to an increase in blood pressure. This should be followed by a more prolonged increase in blood pressure due to the effect of epinephrine in activating both alpha-1 and alpha-2 receptors on smooth muscle in blood vessels in the periphery, and activation of beta-2 receptors, which would lead to vasodilatation of blood vessels in skeletal muscle. The net response is an increase in blood pressure. Note the reflex slowing of the heart due to activation of the baroreceptor reflex. The effect of epinephrine is terminated due to reuptake at adrenergic nerve terminals, diffusion of the drug from the synaptic area, and metabolism of norepinephrine by monoamine oxidase and catechol O-methyl transferase. Since butoxamine blocks beta-2 receptors and a large dose of prazosin will block both alpha-1 and alpha-2 receptors, we would expect that epinephrine, if given after butoxamine and prazosin, would only lead to an increase in blood pressure due to activation of beta-1 receptors. As predicted, epinephrine after butoxamine and prazosin gives a small increase in blood pressure due to activation of the beta-1 receptors in the myocardium. Because arteriolar and venous tone are determined to a large degree by alpha-1 adrenergic receptors on vascular smooth muscle, alpha-1 blocking drugs would lower peripheral resistance and therefore blood pressure. Prazosin, an alpha-1 blocker, can therefore convert the epinephrine pressor response to a depressor response. Following an injection of epinephrine 1.5 micrograms per kilogram, we anticipate a pressor response. The initial phase being due to beta-1 receptor activation in the heart, which is followed by a more sustained vasoconstriction mediated through both alpha-1 and alpha-2 receptors, leading to an increase in blood pressure. Beta-2 receptors are also activated at this stage, but their response, which is vasodilatation, is outweighed by the vasoconstriction. If an alpha receptor blocking drug were administered prior to epinephrine, we could abolish the vasoconstrictor phase, and therefore a vasodilator phase would become evident. Prazosin at high enough concentration will block both alpha-1 and alpha-2 receptors, and we would convert the pressor response due to epinephrine to a depressor response. In other words, we reverse the response to epinephrine. Prazosin, 10 micrograms per kilogram, was injected before epinephrine, 1.5 micrograms per kilogram. As anticipated, a decrease in blood pressure is obtained. This is due to activation of beta-2 receptors in the blood vessels of skeletal muscle. We would have expected a small increase in blood pressure to precede the decrease. This would be due to the activation of beta-1 receptors. Epinephrine reversal is useful in distinguishing between epinephrine and norepinephrine. Since norepinephrine has no beta-2 activity and would not decrease blood pressure. Norepinephrine, the endogenous neurotransmitter, acts on beta-1, alpha-1, and alpha-2 receptors. The beta-1 receptors located in the heart mediate an increase in the force and an increase in the rate of contraction. The alpha-1 and alpha-2 receptors mediate vasoconstriction and therefore an increase in blood pressure. It's important to note that norepinephrine has no beta-2 activity. Therefore, no vasodilatation would be expected as the drug concentration is decreased. Following an infusion of norepinephrine, we would expect an increase in blood pressure with no decrease below the baseline. Norepinephrine, 0.5 micrograms per kilogram was injected, and as expected, an initial increase is obtained due to activation of beta-1 receptors, and this is followed by a more sustained increase in blood pressure due to activation of alpha-1 and alpha-2 receptors in the periphery. Note the marked slowing of the heart due to reflex mechanisms. There's a marked increase in both the diastolic and systolic blood pressure because norepinephrine does not activate beta-2 receptors, which would tend to decrease the blood pressure due to their vasodilatation. Phenylephrine, an alpha-1 adrenergic receptor agonist, has a structure similar to that of epinephrine, except one hydroxyl group in the ring has been removed. This decreases the potency, but also slows the metabolism of phenylephrine. Phenylephrine thus produces vasoconstriction, leading to an increase in blood pressure, following an injection of 3 micrograms per kilogram phenylephrine. We expect to see an increase in blood pressure due to activation of alpha-1 receptors. As can be seen, a marked increase in blood pressure is obtained. This response is similar to that obtained with methoxamine, the other alpha-1 selective agonist. Phenylephrine has no beta-1 activity nor beta-2 activity. It is also long-lasting in that the drug is metabolized slower than epinephrine. Compounds like phenylephrine and methoxamine have been used in the treatment of paroxysmal atrial or nodal tachycardia, relying on the reflex mechanisms to slow the heart. Isoproterenol, INE, is an extremely potent beta-1 and beta-2 receptor agonist with no effect on alpha receptors. Beta-1 receptor activation leads to an increase in the force and rate of contraction of the heart with an increase in cardiac output. Beta-2 receptor activation leads to vasodilatation and a drop in the mean arterial pressure. Therefore, following an injection of isopropyl norepinephrine, we would expect an initial increase followed by a decrease in blood pressure. 1.5 micrograms per kilogram of isopropyl norepinephrine was infused. As expected, the initial response is due to beta-1 receptor activation in the heart, followed by beta-2 receptor activation in the periphery. Note the marked increase in heart rate, again mediated through the baroreceptor reflex. There's a decrease in mean arterial pressure, again due to activation of the beta-2 receptors. The marked increase in heart rate is due initially to the effect of isopropyl norepinephrine directly on the heart, as well as the reflex effects in trying to compensate for the beta-2 mediated decrease in blood pressure. Dopamine, the immediate precursor of norepinephrine and a central neurotransmitter, acts on beta-1 receptors in the heart to increase the rate and the force of contraction, as well as on alpha receptors in the vasculature, leading to vasoconstriction. In addition, dopamine activates specific dopamine receptors in renal and splanchnic resistance vessels, leading to vasodilatation. Dopamine receptor mediated vasodilatation is easily masked by the more powerful alpha mediated vasoconstriction, which is usually seen if dopamine is infused rapidly. We would therefore expect an increase in blood pressure following a rapid infusion of dopamine. Dopamine, 100 micrograms per kilogram, was injected. As expected, an increase in blood pressure is recorded due to activation of the alpha receptors in the periphery. There's also a marked slowing of the heart due to an increase in the vagal tone because of the baroreceptor reflex. Beta-1 receptors in the heart are also activated and mediate this increase in blood pressure. When this alpha-mediated vasoconstrictor response is blocked with an alpha antagonist, for example prazosin, we can then demonstrate that dopamine will induce vasodilatation. Thus, following an injection of prazosin, 10 micrograms per kilogram, which was followed by dopamine, 100 micrograms per kilogram, we would expect the alpha-1 receptors to be blocked, and dopamine can now act as a vasodilator on the specific dopamine receptors on the renal and splanchnic vessels. As expected, a decrease in blood pressure is obtained in the alpha-blocked dog following administration of dopamine. Dopamine has the ability to increase renal blood flow while producing a positive inotropic effect as well as peripheral vasoconstriction. And this is considered useful in the treatment of cardiogenic shock where perfusion to the kidney is important. We know that the decrease in blood pressure recorded is mediated through the action of dopamine on specific dopamine receptors, because the vasodilatation can be blocked with dopamine antagonists. Pimozide, a dopamine antagonist, should therefore prevent dopamine-induced vasodilatation in the alpha block dog. This is shown in the following tracing, in which dopamine, 100 micrograms per kilogram, was injected after prazosin to block alpha receptors and pimozide to block dopamine receptors. No change in blood pressure is recorded. The final objective in today's laboratory demonstration is to demonstrate the reflex homeostatic adjustments of the animal. As already demonstrated with the sympathomimetics, the animal adjusts to changes in blood pressure through the baroreceptor reflex. Baroreceptors in the carotid sinus monitor blood pressure. Afferent impulses are relayed to the central vasomotor center, which in turn modulates sympathetic outflow to the heart and vascular smooth muscle. The baroreceptor reflex can clearly be demonstrated by occluding the carotid arteries. This will lead to a decrease in blood pressure at the carotid sinus and activation of the baroreceptors. We would expect an increase in sympathetic tone and a decrease in vagal or parasympathetic tone, resulting in an increase in blood pressure. The final tracing shows the response obtained when both carotid arteries were occluded in the dog. As expected, an increase in blood pressure is observed. This is due to the baroreceptors being activated following occlusion of the carotid arteries. The baroreceptors will send afferent impulses to the central vasomotor center, which will increase the sympathetic tone to the heart to increase the rate and force of contraction of the heart, and more importantly, to vasoconstrict the vascular smooth muscle, leading to an increase in blood pressure. Since alpha-mediated vasoconstriction plays an important role in the baroreceptor reflex, this response should be blocked by the alpha antagonist prazosin. When the carotids are released and the baroreceptors monitor the normal blood pressure again, the overall blood pressure in the animal returns to normal. This afternoon we've observed the cardiovascular responses to a number of sympathomimetic agonists and antagonists in the dog. Therefore, in summary, first of all, the blood pressure responses to a high and low dose of epinephrine were examined. Secondly, the effects of agonists and antagonists of alpha-1, alpha-2, beta-1 and beta-2 adrenergic receptors, as well as dopamine receptors, and their effect on blood pressure was studied. And thirdly, the role of the baroreceptor reflex in maintaining blood pressure within normal limits was demonstrated.